Shifting gears a little bit, let's now focus on beta blockers. Beta blockers are an important class of medications that must be learned very well for both the exam and during your clinical years. And it's important to know which ones are selective and which ones are non-selective. So beta blockers all will end in LOL, which is only sort of funny if you're below the age of 30 and actually know what that means. So beta blockers can be classified based on their selectivity. Beta 1 selective antagonists are going to be more selective for beta 1 receptors than beta 2 receptors. This includes our betaxolol, esmolol, acebutolol, atenolol, and metoprolol. So they all kind of sound the same. How are you going to keep them straight for test day? A good way to remember the selective beta 1 blockers is that all of them are in the first half of the alphabet, between A and M. So beta 1 blockers are more selective for our beta 1 receptors, and they're good for patients with comorbid pulmonary disease because beta 2 blockade will lead to bronchoconstriction. Our next class is the non-selective beta blockers. Non-selective beta antagonists have equal effects on both beta 1 receptors and beta 2 receptors. Now these will include our propranolol, timolol, nadolol, and pindolol. Most of these agents have the first letter between N and Z for non-selective. That's an easy way to remember it. What about the drugs that end in LOL but block both the alpha and beta receptors? So non-selective alpha and beta antagonists include carvedilol and labetalol. Notice how the endings don't end in O-lol, but this time they're going to end in ILOL or ALOL. So that's an easy way that you can remember our non-selective alpha and beta blockers because they don't end in the nice OLOL, which you'll see with pretty much everything else. So these drugs will block both alpha and beta receptors. And our last one that we're going to touch on is nebivolol. Now this is a confused little drug. It blocks our beta 1 receptor, but it's going to actually activate our beta 3 receptor, which is going to be used to activate nitric oxide synthase, increasing the amounts of nitrous oxide in vasculature, which is going to relax it. So it activates some beta receptors, but it'll block or antagonize others. Here's another flash quiz we can do. A 40-year-old female has worsened wheezing after taking propranolol for hypertension. What's the mechanism behind her wheezing? I'll give you a second to think about this one, but notice how I keep returning to our list of different receptors. I said that if you struggle with this list, then maybe you should make note cards on the different receptor types. This will pay off huge for test day. Okay, think you have the answer? Propranolol is a non-selective beta blocker. Non-selective beta blockers prevent vasodilation and limit the effect of asthma medications like albuterol, that's a beta agonist. Even simpler, beta blockers cause bronchoconstriction because beta 1 agonists, or beta 1 stimulators, cause bronchodilation. Albuterol is an example of a beta 1 stimulator, which is why it is useful for treating asthma, because remember, it bronchodilates. Now, we aren't done yet. I have another question for you. Is timolol, is that a beta blocker that is a non-specific beta blocker, meaning it'll block both beta 1 and beta 2? Is it a non-selective beta plus alpha blocker, or is it a beta 1 selective blocker? Well, this goes back to our discussion on selectivity of our beta blockers. Remember that beta blockers that begin with N through Z are usually the non-selective beta antagonists. Remember, N for non-selective, meaning they block both our beta 1 and beta 2 equally. Therefore, timolol is a non-selective beta blocker, just like our propranolol in the example here. We just classified the beta blockers based on their selectivity. Now let's take a step back and look at how beta blockers are used clinically. Indications for the use of beta blockers include multiple heart and vasculature conditions. First, beta blockers are going to help with angina pectoris because beta blockers are going to decrease the heart rate, and decrease the contractility, which results in a decrease in oxygen consumption by cardiac tissues, and this can help alleviate the chest pain. Beta blockers are also used in cases of MIs, because beta blockers have been shown to decrease mortality. Beta blockers can also be used to treat supraventricular tachycardias. A supraventricular tachycardia is caused by a rapid excitation above the AV node. So here in the diagram, let's look at normal conduction. The SA node is going to initiate the impulse, which it travels down to the AV node. The signal is delayed then for the ventricles to fill up with blood. There are many different causes of SVT, but all of them share the same characteristic of sending impulses too fast down through the AV node. So here we see multiple impulses that are being sent faster than they should down to the ventricles. Now, why do beta blockers help with SVTs? Recall from the cardiovascular section that there are many different types of antiarrhythmic agents. Class 2 antiarrhythmic agents are certain beta blockers such as metoprolol and esmolol. Class 2 antiarrhythmic agents are going to decrease or slow down that AV node conduction velocity and therefore are helpful in the treatment of supraventricular tachycardias. Beta blockers are also used for hypertension, since beta blockers decrease the cardiac output and they also decrease renin secretion. So let's think back to our renal section, where our juxtaglomerular cells, or JG cells, have beta-1 receptors on them. When these beta-1 receptors are stimulated, renin gets released, which is going to activate our renin-angiotensin-aldosterone system, the RAAS system, which will increase our blood pressure, along with other effects. However, if we introduce a beta blocker now, we can decrease the renin-angiotensin-aldosterone system, which is going to help with treating hypertension. So beta blockers are going to block the beta-1 receptors, actually decreasing renin release. So beta blockers are also used in congestive heart failure, since beta blockers slow the progression to chronic heart failure. Beta blockers have been proven to decrease the mortality rates when given in cases of CHF. And lastly, beta blockers are used in the treatment of glaucoma, for which timolol is effective because it decreases the secretion of aqueous humor. Since the use of beta blockers is widespread, it's important to recognize beta blocker toxicity. Now this includes impotence, asthma exacerbations due to the blocked beta-2 receptors. So remember our discussion about asthma earlier? Beta blockers can cause bronchoconstriction, so be careful when giving beta blockers to patients with asthma. Beta blockers also have adverse cardiovascular effects such as bradycardia, AV nodal block, and CHF. And lastly, we see CNS effects such as seizures, sedation, and changes in sleeping patterns. Furthermore, metoprolol can cause dyslipidemias. So we're now halfway done with pharmacology. There was a lot of information in this section that'll be important on test day. I'd recommend making sure you're comfortable with the different receptors and drug categories before going into the test. This way you'll be able to pile on the points. Thanks for sticking with me. Only 2 more sections of the pharmacology section to go. Let's do a few questions. A 62-year-old man who's been in the hospital for the last 4 days begins to decompensate in the middle of the night. When examined, his blood pressure is very low at 60/30. His pulse is tachycardic at 112. And his temperature is 105 degrees. His breathing is rapid and shallow, and his arms and legs are warm to the touch. The patient is immediately given a 2-liter bolus of IV fluids with no resulting change in blood pressure. He's then admitted to the ICU for suspected septic shock. Which of the following drugs should be used initially to stabilize this patient's vital signs? Is it A, clonidine, B, metoprolol, C, norepinephrine, D, phenoxybenzamine, or E, vancomycin? I'll give you a second to think about this. Okay, so looking quickly at the question prompt, we see that the patient is hypotensive. Now, we also give a 2-liter fluid bolus that has not helped with this blood pressure. We need to give a drug now to treat that low blood pressure first. So which of the drugs on this list should be given? If you chose C, norepinephrine, you'd be correct. So let's talk about this quickly. The patient is presenting with hypotension, and now we need a drug to increase the blood pressure. So how are we going to do it? Well, let's activate alpha-1 receptors on the vasculature smooth muscle, which will cause our vasoconstriction. Norepinephrine is an alpha-1 agonist, which will lead to vasoconstriction and thus raise the patient's blood pressure. Clonidine, choice A, is a selective alpha-2 agonist, which is going to be used to treat high blood pressure, but not actually raise the blood pressure. Option B, metoprolol, is a selective beta-1 blocker that has chronotropic and inotropic effects. Metoprolol will actually decrease both the blood pressure and the heart rate, which would make this 62-year-old even worse off. Option D here, phenoxybenzamine, is a non-specific alpha antagonist, which is used in the treatment of pheochromocytomas. I don't think the patient has one right now, so we don't want to block the alpha-1 receptors. Instead, we would actually want to activate them, so this would make us worse off as well. And then last, option E, vancomycin. This is an antibiotic, but it's not really going to affect the blood pressure. We need to initially stabilize the patient's vital signs. This would not be the best choice, so that's why we get C, norepinephrine. I want you to pay close attention to this question. This will be a multiple part question, just like you could see on test day. A 25-year-old laborer on a fruit farm is brought into the emergency room by a coworker because he's having diarrhea and difficulty breathing after the lunch break. His heart rate is low in the 50s, blood pressure's high, respiratory rate's a little abnormal at 23, and the temperature's pretty unremarkable. On physical exam, he's diaphoretic, drooling, and unable to answer questions coherently. What should the physician give to treat this condition? I'll give you a second. Okay, so the correct answer option here is B, pralidoxime. Now, does this question look familiar to you? I can almost guarantee you'll see something like this on test day. The USMLE loves this concept. Someone on a farm who comes in with high blood pressure, bradycardia, this wet picture of diaphoresis, drooling, and confusion. So what are these symptoms? Aha! Well, remember I said earlier that insecticides such as parathion can inhibit the enzyme acetylcholinesterase, which is going to break down the acetylcholine in the synaptic cleft. If you have too much acetylcholine, that can cause cholinergic stimulation, which is going to lead to diarrhea, meiosis, bronchospasm, sweating, bradycardia, and salivation. Acetylcholinesterase inhibitors are often reversible only for a short period of time, so it's important to administer pralidoxime, a component that's going to regenerate your active cholinesterase, which is going to be needed to reduce your acetylcholine levels. Now, let's look at some of the options here. Choice A, dantrolene. This prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscles. It's often useful in the treatment of neuroleptic malignant syndrome and malignant hyperthermia. Option C here, pyridostigmine, is an anticholinesterase used to treat myasthenia gravis. It would actually make this patient's symptoms worse by increasing the acetylcholine levels. And then lastly, option D, succinylcholine, is a depolarizing neuromuscular blocker that's used in anesthesia during intubation. Make sure you're comfortable with this question because I can almost guarantee something may show up like this on test day. So let's look at the next part of this question. Pralidoxime is not available in the clinic that you're working at. This patient's symptoms are getting worse and you, the clinician, need to give him something to help. What other drug could you give for acute acetylcholinesterase inhibitor poisoning? And I covered this drug earlier in the section. Alright. Answer is going to be atropine, a muscarinic antagonist. It's going to block the muscarinic receptors so that excess acetylcholine will stop causing all of these symptoms. So in review, atropine and pralidoxime are the two treatments for acetylcholinesterase inhibitor poisoning. Make sure you know the treatment for parathion poisoning and what the mechanism behind the treatment is.